Good morning. It's a great honor and privilege to be the first speaker in this wonderful conference and to represent the Israeli Society of Critical Care. Can I have the first slide, please? That is not the first slide. It's cut. Is it possible to make it not cut? Okay. All right, so I'm going to talk about innovation in the ICU. Next slide. Can I move the slides? Okay, so I will present a patient, of course. This is a current patient in intensive care unit in my unit. 51 years old, 160 kilo patient admitted about 2 weeks prior to admission to intensive care to the hospital to investigate jaundice, some mild jaundice. He is now in a general department and he has an IV line. And that IV line gets infected. A few days later, Staphylococcus is grown out of his blood. He develops severe endocarditis, septic shock, then respiratory failure, needs mechanical ventilation, which is quite difficult to intubate and to ventilate, heart failure, renal failure, comes in resuscitation mode with adrenaline pushes into my unit, and after stabilization, which takes about 2 days, gets a mitral valve replacement, and still is alive, but not doing too well. Can you see here, he's on 2 mechanical ventilators. One is a regular, this is high-frequency jet ventilation here. He has a cardiac output monitor. He has a dialysis machine, which has a special filter to remove cytokines from his blood, and after about 24 hours, he's stabilized and good enough to go to surgery. So why do we have to be innovative in the ICU? We need to create intelligent clinical systems. We want to reduce clinical and medication errors. We want to improve patient safety, to reduce hospital-acquired infections, to improve decision-making process in intensive care and in the hospital in general, to engage patient and family, and to improve ICU culture and teamwork. So in the context of this patient, what do we need? We need to be able to predict that this patient is going to have a bacteremia before it actually grows, so that we stop this cascade of terrible events to lead to the patient's most severe complication. He needs a valve replacement because of an IV line. That we predict that he's going to have a bacteremia before it actually occurs, and that we treat it before that. So how can this be done? We've done it. We've developed an algorithm with a machine learning process that is unit-specific and hospital-specific, that can actually take all the data from the patient. This is in the ICU, not in a regular department yet. It takes the data from the ventilator, from the monitor, from the laboratories, from x-rays, from everywhere, and has the history of the patient and will give us an alert that this patient is going to have a bacteremia 2 days from now. And this is an algorithm that's unit-specific, and each unit can actually develop it in their own unit for their own situation and culture. Can we predict ventilator-associated pneumonia in patients? One of the major complications in intensive care is about 15 to 20% of the patient, after 5 days on the ventilator, will develop a new pneumonia that they didn't have on admission. It's called ventilator-associated pneumonia. Many times, very bad bacteria, gram-negative aerobes that come from the gut. How can we diagnose this early enough? So there is an Israeli company, Respiratory Scan. We've done a proof of concept study, and they investigate the air that's exhaled from the patient with the mass spectrometer, gas chromatography, and can detect the existence of bacteria or what they excrete in the air of the ventilator. This will be able to notify us this quantitatively and also qualitatively that this patient has bacteria in the lungs in a significant number, even before the culture is positive, even before the X-ray shows an infiltrate. We will already know which bacteria they have and how many, and we can treat it before we see the signs of pneumonia. One of the major problems in COVID patients in the first wave was that a lot of patients got intubated and the death rate was very high. So in the second wave, people were afraid to intubate the patients. You may remember that. And then patients were kept on non-invasive techniques for too long and not intubated in time. So in Beilinson Hospital, they developed an algorithm, machine learning algorithm, that can predict and detect when is the right time to intubate the patient. And this has already been, so this is a novel machine learning model with a great area under the curve, 0.92, that can predict which patient is going to need intubation for COVID. And one of the major problems in intensive care is feeding the patient. You know that feeding is extremely important for patients, and it has a great effect on outcome, on infection, and length of stay and length of mechanical ventilation. And one of the problems is the patient develop reflux. If they're fed, that they have gastroparesis and they have reflux, and then after that aspiration pneumonia. And many times feeding has to be stopped for many reasons, because of transport to the operating room or transport to CT or other procedures, and they don't get enough feeding. So an Israeli company, Art Medical, has developed a robot that can detect the amount of nutrition in the stomach, that can detect reflux, that can do correction for the feeding that has been not given to the patient over so many hours during the day. And if the patient develops reflux, can drain the stomach so that the reflux will not develop into an aspiration. So we've done the first proof of concept in our department, and a prospective controlled study is going to be published soon from Beilinson Hospital in the JAMA on outcome of mechanical ventilation, length of stay in the ICU as a result of robotic feeding of the patients. So what is going to be the future of intensive care? Hospitals will become smaller because many patients will be treated at home. However, the amount of intensive care in the hospital from 5% is going to go up to 30%. And you will find intensive care doctors everywhere. You will need intensive care doctors in the general ICU, in the medical ICU, in the surgical, corona, neurosurgical ICU, in cardiothoracic, and burns, and stroke, and of course all the pediatric and bone marrow, and new places like the step-down unit and the follow-up clinic and outreach and transport and so on. We will need a lot of intensive care. This has been proven in the corona pandemic how important intensive care is. And artificial intelligence is going to be an extremely important part of it. Yes, the ICU is going to be very pretty, but under this bed, there will be a smart ICU. And what does that mean? The bed is going to be connected to a lot of computerization. All the data from the patient, I will finish soon. All the data from the patient is fed into computers that are going to predict with artificial intelligence what is going to happen to the patient. Yes, there will be a physician at the bedside. However, there is going to be another physician in the background, sometimes from far, that is going to monitor everything with the patient. This can be done, of course, partly automatically by artificial intelligence, and from afar with hubs like that the patients are going to be followed. So finally, the ICU of the future is going to be a place where there's going to be a lot of technology. We already have a lot of technology, but it's all going to be connected to big data, to robotics, to system integration, to cloud computing, and augmented reality. Okay, I thought what's going to be the last slide in my presentation, and I didn't have one. And yesterday evening, I went to see the new film from Steven Spielberg that you all should see about his childhood. And I went to the toilet, and there I found the high technology slide that is going to be my final slide. It says in Hebrew, "Man, you're beautiful. Don't forget to wash your hands." Thank you very much. Okay.
Don't worry, we will give a